All right, this is another lobular tumor, pretty well circumscribed, but it's much more blue, right? It's a solid blue lobules in the dermis. Also has some cystic spaces in it. And when we get closer here, we can again see sebacites. Very nice, vacuolated. The vacuoles are a little more fine and delicate in this case, but you can definitely see nice, obvious sebacites in here. And then again, these background germinative basaloid cells, which are very uniform, they have small nucleoli. And if you look around, you'll find mitoses. So I feel like in the literature, there's not a lot of discussion about that, unless I've overlooked some papers, that when we're talking about how to tell if a sebaceous tumor is benign or, okay, someone said I should give 5 seconds to give the answer. That's a great idea. I will do that. So if you look around, I feel like I see mitoses in almost every sebaceous neoplasm, both benign and malignant. And the way I found that out is I was giving a course a few years ago, and I was trying to pull examples of benign sebaceous tumors, and I couldn't find any examples in my entire recut collection that didn't have mitotic activity. So either I've misdiagnosed a whole bunch of sebaceous carcinomas and called them benign, and I'm knocking on wood, hopefully that's not true, or it's just that mitoses are actually present in these cells. So I don't get too worked up about finding mitoses. I do get worried if I see atypical mitoses, like tripolar mitotic figures, or pleomorphism, or infiltrative invasive growth. Those things are all concerning to me. Okay, so then what is, I will let you guys decide. We've got obvious sebacites, blue basaloid cells, and the basaloid cells make up the majority of the tumor, more than half of the tumor, whereas the sebacites, the mature sebacites, make up less than half the tumor. So what is the diagnosis? You're welcome to type it into the chat if you want. You'll get a invisible bonus point from me if you get it right. Or you can just quiz yourself and know in your heart the joy of making the diagnosis. Okay, I see someone. There we go. 5, 4, 3, 2, 1. Yeah, this is a sebaceoma. Sebaceoma is basically, in my view, on a spectrum with sebaceous adenoma. So don't lose sleep over deciding whether to call something sebaceous adenoma or sebaceoma. It doesn't matter. They're both benign sebaceous neoplasms. And it's, in my opinion, purely an arbitrary distinction that we've made by saying if it's more than 50% basaloid blue cells, then it's sebaceoma. And if it's more than 50% are the mature sebacites, then we call it sebaceous adenoma. Okay, cool. Sometimes in dermpath, we like to split a little bit too much. And I think splitting's fun for conferences and for teaching. But in the real world, we have to think about what really matters for patient care. And the point is that both of these tumors are benign, but have the potential to be associated with Muratori syndrome. And Van Hung makes a very good point that this is a great time to get the diagnosis wrong. Because A, the chat screen is hidden from the video, so maybe your colleagues will see that you got it wrong, but no one on the internet will, okay? And the other thing that is important about this is that if you get it wrong, no one dies and you don't get sued. And I like to tell my residents that, and it's kind of that I'm joking, but also it's totally true. When you're in training or when you're in a conference, it's a great time to look at a case and say, I think this is the diagnosis, and to be totally wrong, because that's how you learn and how you set your internal diagnostic thresholds. How you, when you look at something and you realize, man, the last 3 times I saw this tumor, I thought it was benign, but it's actually malignant. Then you learn that's a tumor I need to spend more time thinking about and studying and looking at. And I think that's a great way to learn. And I actually do that even to this day, even though I'm not a trainee anymore, on the internet when people show cases and I say, oh, I think this unknown case is going to be this. And then they're like, wrong, it metastasized. It was actually melanoma. I'm like, well, that was a hard case. And it's good to see what things I look at and get right and which things I get wrong. This is the way that we adjust our gut feeling, right? And if you haven't read it, there's a really great book by Malcolm Gladwell called Blink. And I think it should be required reading for all pathologists, probably for all doctors, because it's all about how we look at things and make subconscious decisions before we are cognitively aware of it. That there are little, the underpinnings of the way our brain works are picking up little details. And so that all of that technical stuff there, I think amounts to what we have that we call a gut feeling. And so I can realize that sometimes my gut feeling is, ooh, I'm worried about this, but it ends up being benign. And if the last 10 times I was worried about something, this certain thing, I realize, oh, that always looks scary, but it ends up not being scary. And so that's how I adjust my gut feeling. So in any case, there's a little bit of philosophy lesson for you today, but I think it's a really great way to learn. I still remember cases from residency where I was wrong, where a junior resident told me they thought it was something, and I was like, oh no, I'm the senior resident, I'm going into dermpath. Oh no, I was totally wrong. And I still can't get over those things, but I remember, and hopefully that will help me help my patients one day. Okay, thank you for letting me preach. I appreciate it. Now, this is a sebaceoma. All right, so let's move forward.